Thank you. I'm happy to be there. I wish I could be there to acknowledge Dr. Meek one more time. This is an idea that he had that, I think a lot of people have ideas, but getting them, all the way to where they need to be and in the hands of clinicians is a really important thing. This is where I am today. And I wish I was with you guys. If y'all saw what I was doing today, you'd be very, very sad. I also want to tell you, I just saw a patient with one of our CurvaFix patients yesterday in the clinic, and he's at his 3.5-month anniversary after his surgery, and he's returned to work as a heavy laborer despite his colostomy bag. And I actually released him. I forgot about the study, and so I'll make sure when he comes back to get his bowel hooked back up that we get the 1-year follow-up that you want. So I'm going to stick to just discussing 2 patients today. And these are both acute fractures. One of them, I think, is just a great indication for CurvaFix, just to sort of emphasize what we could and can and should be using it for. And then I'm going to present another patient where I really wish I would have used the CurvaFix. I think I had a real missed opportunity, but we'll get into that. Our first patient is a 28-year-old. He's in a car wreck, unable to walk. He describes his pain 9 out of 10. I think y'all all know these patients. He won't move in the bed or do anything as long as he's perfectly still. His pain is about 6 out of 10. He's hemodynamically stable and otherwise normal. And this is his AP film. And on the AP film, you can see his sites of injuries. You can see he's in a binder, and the binder is revealing the sites of injury even better. The binder is revealing the displacements, and the binder is probably causing the displacements and showing you what's unstable. When the binder's removed, he gets this so-called rebound reduction, not a perfect AP film, but you can still see his sites of injuries. And then the surface renderings with the contrast are always very beautiful imaging, but sometimes they cover up the pathology. So you can see the iliac vessels on the left cover up the sacral injury somewhat, but if you notice, you can also see his communicating vessel from his iliac system to his obturator system, really a beautiful example of that. And then you can see not a lot of deformity when he's not in the binder as a result, but again, obstruction of the surface renderings by the contrast. You can see he's probably the skinniest guy in Houston, Texas, and not much of a sacral injury. You can see where it collapsed in the anterior portion of the cortical bone. And then as we track down, you can see his second sacral segment, and also the dorsal cortical injury is really not much of an injury. You'd anticipate that perhaps this patient could be treated without operation. He would beg to differ with you. On the axial images, as we track through the hips, you can see the contrast enhancement of the vessels and also not much deformity. There's this communicating vessels seen beautifully on the CT scan. And then the superior ramus comminution, inferior ramus displacement. And so we're left with this patient in this situation, but we would offer him the chance to mobilize, and he's going to refuse. He won't get out of bed. He won't move in the bed. And so we offer him this opportunity to be stabilized and reduce somewhat. This is his stable side on the right, and then you can see we already know this. We do this for teaching purposes, but we don't have to do this exam. This is just 5 to 10 pounds of manual pressure on his iliac crest, directed toward the midline, applied bilaterally, and you can see the instability gets revealed as a result of this, just like for the binder. There's so many different options you can use for treating patients. We opted to stabilize the sacral fracture with several iliosacral screws that were directed to accommodate the pathway. This was his soft tissues on his flank. And so when you see soft tissues like this is not a insignificant injury, and you may want to change some of the things that you do. We opted for, I don't know what y'all call this, but a ramus screw, a superior pubic ramus screw that's put in from the supraacetabular area toward the pubic ramus. We call this an antegrade ramus screw. And we use this 2-millimeter Kirschner wire to make sure we're in the right spot on the skin and we get the right direction to the bone and that we're anticipating where we're going. And then I just usually use a 4-5 cannulated, calibrated drill to prepare the pathway. But I think you can see on the inlet view, we're in a little bit of trouble if we're using a straight implant. Now, I would challenge this and just say if I would have just oriented my hand a little bit differently on the obturator outlet image, I could have made this pathway work for a straight implant. And if I'd have started more anteriorly, I could have made this implant work. But as you all know, I hope you know that this pathway of bone in the area of the anterior wall is extremely narrow and risks the screw being in, or just out. And for this reason, that's why we start where you see the drill, and why we don't start where you see the black arrow on the inlet view is for that very reason. So we're faced with this problem. This is the guide for the opening reamer, or for the initial CurvaFix opening reamer. And we've just put that guide into the 4-5 pathway that we prepared. This is the opening reamer that's put through the percutaneous wound. And then this is the ball tip guide. And you can see we can curve it at its tip to put it where we want it to go in the medullary pathway. And then we can ream and prepare this area to make sure that the pathway is prepared for the device. We can use a switching tube. You can see on the left side and on the right side, the radiolucent, almost radiolucent switching or exchange tube that allows us to put you can see on the left, the ball tip guide, and exchange it for a device passing, just like you might do for a femoral nail. And then you can see we get a length measurement and then just apply the device. And this is the 7.5 millimeter diameter device. And we sort of get to this crucial point on the inlet view where you can see the device needs to make a turn, and it makes the turn just following this pathway that we prepared. And then, as Brett pointed out, Dr. Chris pointed out, this is the self-tapping edge just burrows its way through the pubic tubercle to nestle into a nice reduction and nice accommodation of the pathway. So post-operatively, as I think you all know these patients. We know these patients. His comfort after surgery is now a 1 out of 10, and he actually was discharged to home the next day. We kept him for 24 hours of antibiotics, but sometimes these patients go home that evening. We like a CT scan to assess our work. I think you can see the posterior portion of the fracture a little bit better. And then where the CurvaFix device is nestled in the superior ramus pathway, just as you'd anticipate it to be, not too long, not too short, but just like baby bear, just right. And then again, you can see if we'd have been a little more anterior, we wouldn't have had any pathway availability for our device, no matter what its diameter, because there's just not bone there. So we like site-specific stability. We like our implants to accommodate the pathways. We certainly like to correct the deformity and then provide stability. These are all the things that we do, no matter what bone or what joint we're taking care of. And then the CT scan shows us where things are and what we did. The other patient I wanted to talk to you about is just one that I wish I would have, I really wish I would have used the CurvaFix for in several applications. And I'll go a little bit quick through some parts of this. Again, this is a plumber. He actually fell about 4 stories through an elevator shaft and was hemodynamically unstable. And you can see he's a really active guy, owns his own business, still working really hard, and actually is addicted to work. He'd make a really good orthopedic trauma surgeon. He's got true passion for his work. You can see he's had a previous spine operation. That's his iliac crest is missing some bone there from the graft, and that's his sacral injury, his ramus injury. And then you can see his left-sided sacroiliac injury is not really apparent, but that's a crescent iliac fracture with a sacroiliac articular injury. And that's where the problem is going to be. I think if I told you I was going to have a problem with this case, you would say, well, something's going to go wrong with the right hemipelvis. That sacrum is really bad and that ramus is really bad. But what happens to us is our iliac fracture, this left-sided posterior ring, really causes us some problems. And I'll just show you what we did. There's the iliac fracture that you can see there on the lateral surface rendering. So this is the problem where the crescent iliac injury is. And so if we're going to stabilize this, if we try to do a closed reduction, we've got to make sure that we locate our implant, in the unstable piece and not so close to the fracture. But even if we get it right, it's still sometimes just by the nature of this iliac fracture, it's just close to where the implants insert. And then you can see the ramus deformity here. He had an arteriogram, got an embolization, and was hemodynamically stable after that. So we used closed reduction. We used frame to help get the ramus pretty close. You can see on that outlet view on the right, the ramus is sort of like a Venn diagram, to use Kamala Harris's terminology. It said that it is a Venn diagram, but again, it's a three-dimensional Venn diagram. And you can see we've gotten a compression. We could see the sacral fracture gap, and so we could watch this on the C-arm as we tighten the lag screw to get a compression reduction. And then we're managing to get through this three-dimensional tube misalignment to make sure our 7 millimeter screw is inserted between those tubes of opportunity, and then also make sure the screw is bicortical. And then we go to the left side, and this is part of our problem. We end up with this construct, you can see, which I think most of you would think would be sufficient. But in retrospect, I really wish we'd have used a CurvaFix at the second sacral segment level and started it, and I hope you can see my cursor, more anteriorly, and then also this iliosacral screw more anteriorly, and gotten it more on the unstable part. When you look at the post-op CT scan, things are looking pretty good. The sacral reduction on the right looks good. And the crescent, for a 58-year-old guy, we're pretty pleased with this closed reduction, but we're worried about the screw location adjacent to the fracture. Same for the second, and also the second sacral segment screw here, right on the fracture. And as you know what's about to happen, everything looks fine from the ramus standpoint as well. You can see the ramus is, even though it's not a perfect reduction, it's sort of getting through the space of opportunity properly. But again, if I had this to do over, I wish I would have used a CurvaFix in the front, and I wish I would have used a CurvaFix in the back on the left side to enter more anteriorly. And you can see where our frame was for manipulation. And then we could have also used the CurvaFix to even dodge. We could have made that hump and bump a little bit around the implants, the iliosacral screws as well, so that this could have been a little bit more coordinated dance of fixation. And then at 6 days, he's having some pain. You can see he's lost his fixation on his left side mostly, and the ramus screw is disengaged as a result of that as well. Not much change on the sacrum, but significant change on the crescent iliac injury. And so I'll just, we revised this and did open surgery. We removed the iliosacral screws, removed the washers, did an open reduction with him prone, put in some lag screws, put on a plate like you would if you did an open reduction of a posterior iliac injury, and then added some new iliosacral screws. And this is our posterior construct. Exchanged the screws on the right sacral injury, and then remove the ramus screw. And again, this is how we left him. There's lots of points to consider here. He's gone on to have an uneventful post-operative result, but again, it took him 2 surgeries, and I think a lot of people would be uncomfortable leaving the ramus gapped like that. You could always add a frame, but again, you're adding a frame to where you've got this fixation construct. You might have to change that plate screw a little bit if you're going to add a frame. And then the frame, of course, changes their post-operative regimen a whole lot. Anyway, post-op, you can see the implants, and I don't want to belabor the point, but I wish I would have been a little smarter in my initial planning, and I think the CurvaFix on the left side especially would have helped us avoid a second surgery, and could have helped us really fortify the fixation of the left side, make it more precise to where we wouldn't have this fixation failure like we had with the screws being too close to the fracture. Anyway, those are just my 2 contributions to the day, and I'm going to stop my work here, and I'll turn it back over to y'all, and thank you for the chance to speak. I also hope y'all have a great meeting at the OTA, and I want to thank again Dr. Meek for his work on not just his work on this and the idea, but just the drive to get it to clinicians that need it. And that's all of you that are doing the work. So thank you very much.